for your final test. So let's look at your review sheet. And I don't know, I put 3 through 50, and I know there's not 50 questions. Let me look at the
I
study
think that
guide.
was supposed to be your other, like,
I know, so I must have put I know what I did. I probably shifted or didn't shift and do the other parentheses. Page 95, I think there's only 5. So, page 95, yeah, I think I have 3 through 5. So if you want to correct that on your review sheet, let me turn on the Almo. So that should be 5. It's the last 3. 96 isn't a long one either, but we're going to concentrate on the review on 96 more. Because you already know when you're doing the factor deficiencies, what's your essay question going to be? You already know it from last week. And you already have the sheet of factor deficiencies that I gave you last week. Oh, sorry, I don't have it pulled down far enough. It's 3 to 5. That was supposed to be a parentheses instead of the 0. I must have did my shift wrong enough. So that one, I think you're going to have to be able to tell me. If I give you a list of clotting factors, you're going to have to tell me what happens to the pro-time of PTT. So if I say 1,
both increase.
both increase. If I say 2,
Both increase.
if I say 3, it's your reagent, so no. If I say 4, you don't put anything. It's just required throughout. If I say 5, what do you say?
Both increase.
If I say 6, it's unassigned. If I say 7,
Only increase, PT.
if I say 8,
Increase PTT.
9,
Increase PTT.
10,
Both increase.
11,
Increase PTT.
12.
Increase PTT.
What if I said Fletcher factor and Fitzgerald factor? What do they do in low concentrations? They affect one system, not the other. Intrinsic. They help factor 12. So what's going to be elevated of a pro-time and PTT? If they affect factor 12 and they're deficient, it's an elevated PTT, normal pro-time. And then what about factor 13?
Both normal.
And I think they're on that back side of that sheet. Someone just have that out. Look at the back side. What do they say about Fletcher and Fitzgerald on the back side? Isn't it on the back side? Or does it say anything about Precalican and Fitzgerald at the top?
Abnormal
DT.
or Fitzgerald
And Fletcher. That's on that sheet. So if I give you a list, you got to tell me what the pro-time and PTT do. Okay, now what's your essay question on? You already know it. And you got to give me 4 things on each factor. So what's the question? Pick 2 factor deficiencies, and what 4 things do you have to tell me about? How it's inherited, what kind of bleeding symptoms, what lab tests are abnormal related to coag, and how do you treat it if there's any treatment. So if there's no treatment, you say none. Like 12, you would say asymptomatic, so usually there's no treatment. You pick any 2 that you find easy for you to remember. I'm not telling you which 2. Okay? Your case studies are going to be on DIC and primary fibrinolysis. So that's what I wanted to put up on the board. Okay, so you have primary fibrinolysis and secondary, which is DIC. You have your pro-time, PTT, you have your fibrinogen, your platelet count, and your D-dimer. Okay, Tell me, how do you get primary fibrinolysis? Tell me an example. It's an activator of plasminogen to plasmin that comes from an area in your body, and you can have a procedure. Do you remember the area?
Urological exam.
Okay, and it releases what activator?
Urokinase.
Urokinase that triggers plasminogen to plasmin. There's no clotting whatsoever. So what will plasmin go break down if there's no fibrin clot? Fibrinogen. So you're going to have degradation products X, Y, D, and E, but you're going to have any D dimers? No. Okay? The ProTime and PTT, why are they elevated? If you're acting on fibrinogen and you're getting rid of it and degrading it, you're not going to be able to clot in a ProTime and PTT. That's what makes your fibrin clot. So these are elevated. What happens to your fibrinogen level if the plasmin isn't breaking it down?
Decrease.
Decrease. What happens to the platelet count?
Normal.
Because there's no fibrin clots. The platelet count is normal. And what happens to the D dimers? There's none because the urokinase triggering plasmin, it has no fibrin clot, it goes to the fibrinogen. These are gonna be your key 2 tests. So, there's no clot formation, so you gotta understand there's no fibrin clot. Plasmin acts on fibrinogen. It degrades factor 1, fibrinogen. Tell me 3 ways, I gave you as examples, what could trigger DIC. What releases factor 3 that starts clotting throughout your circulation? What's the example? Placenta pulling away releases factor 3. That's an example. What acts on factor 12 starting clotting? The book highlights a sepsis. A gram-negative sepsis will act on 12. What acts on maybe 10, 2, or 1 to start clotting? A snake venom would be an example. You could go to surgery and your body's going to say, oh my gosh, we just got cut, we got to get all our clotting factors going. So DIC, clotting is present. So you have a fibrin clot. So anytime and remember, it's disseminated. There are clots everywhere. You are utilizing up your factors. That's why your ProTime is elevated and your PTT is elevated and your fibrinogen. You are using up your clotting factors. That's why they're elevated and factor 1 is decreased. Here, factor 1 is degraded. You got to have factor 1 to form the fibrin clot. Remember, that's the last step. Thrombin acts on fibrinogen to become the fibrin clot. This is why the ProTime and PTT are elevated and the fibrinogen is decreased. This is why they're elevated and decreased on this side. Okay? Then tell me what happens to the platelet at D and D dimer and why. Anytime you have a fibrin clot, your platelets are going to be used because they're the platelet plug first and you join the fibrin clot to it. They're used up in DIC. Remember, this is happening all over. That disseminated intravascular coagulation. And then what happens now? Are there D dimers? Yes, because you had the fibrin clot. So if it helps you to write fibrin clot, then you're going to have D dimers and they're going to be positive. So this is the Hallmark 2 test to know you're in secondary and not primary. This is very rare, but it can happen, and that's the example they usually give you.
And what is the patient's problem?
And which one? They have a urological exam that releases urokinase. and it says, hey, plasminogen, become plasmin. They're not bleeding at all. They can bleed now. Why can they bleed? Why in acute? These are all acute that I'm having you know. Why can they bleed? What happens if the degradation products build up and you don't clear them through your liver? Which one can clot at all of the four? Do you remember what I told you? Only X. So if you have all these X, Y, D, and E's in your circulation, and they got to get that baby out of there, especially DIC, what you're going to do is treat the cause. In the case of the pregnant patient, you want to deliver that baby and clear out that placenta. In the case of the gram-negative sepsis, you want to give them antibiotics to treat that infection as fast as you can. In a case of a snake bite, you want to give them antivenom as fast as you can. What happens if in acute you have so many degradation products, in this case, that aren't being cleared? Why would you bleed up here? What's being degraded? That's your main factor.
That's what I'm saying, that would be their issue.
But what if they're doing an invasive procedure? There's always a chance of bleeding. If they're going into your kidney, for example, my sister, I bet, was in DIC. She lost a kidney. She had a major infection that went up into her kidney. They could not treat. They tried to go directly into her kidney with an IV to get antibiotics into the kidney, and she started bleeding profusely. And I bet you any money she had DIC in that case, or in that case, probably a combination, because they were going through her skin to go through into the kidney. But remember, the biggest reason you might bleed here is what are you using up? And if they need to bleed, if there's anything that happens bleeding-wise from that procedure being invasive, they might not be able to clot like a normal person would, okay? Here, this is the biggest reason they bleed. The degradation products are not being cleared. So this is the hardest piece, and you're going to have a case study on each. So you got to understand what are the key distinguishing tests. Look for normal on these two, look for abnormal on these two, because those are your only true 2 case studies, because we had already did so many on the last test. But on the factors, you got to be able to tell me the normal ProTime, normal PTT, and even on your, I gave you the answer key to the primary versus DIC, and I told you, know what happens to the ProTime and PTT for each factor deficiency, and you've got to know on the D-dimer what we used, a positive, negative control. What else did we do in that test when we did it in your practical on the D-dimer? That's your test on this test. 1 to 2 only, but what happens if it was positive at 1 to 2? Continue it from your dilution you had made. That's why you use a pretty good amount at in your 1 to 2. That if you had to continue it, you have that too. And you already said it was negative. You shouldn't have any. And you already know there's clotting that's taken place if the D-dimer is positive. Okay, that's what and you know it doesn't just have to go with DIC. It can be elevated on any blood clot. Deep vein thrombosis, maybe in the calf, pulmonary embolism, myocardial infarction, heart attack, a stroke. If there's elevated degradation from a blood clot being broken down and you can't clear it, that D-dimer, and that's probably going to be where you see it the most, ordered in the ER. And we used to laugh. In 8 hours, we'd get so many D-dimers, and you're thinking, not every patient be coming in with a blood clot. You know, it was like that doctor learned that test, and it was the test of the day, and you're like, that's a lot of waste of money if they truly don't have symptoms of a blood clot. Okay, so this test won't be very long compared to your last regular test. But I think DIC is one of the hardest things for students in the substitution studies. Some students get it right away, and some students struggle with that. But we got to get you to get that. Yes?
I want to ask a question. On the clotting factor disorder study guide, it says number 2 contrasts the 3 genetic disorders, the hemophilia A.
Remember, what are the questions? You got to pay attention. 3.
Okay.
1 and 2 we already tested you on last test.
Okay.
Okay?
That's what I want to know.
So the clotting factor, you're only 3 through 5 on that study guide because we already had those on the other 2 on the last test. Okay? So 3 is that was last test, but you really shouldn't forget it because you need to know it for the substitution studies. You know, it's a building thing, and that's why I do comprehensive. How much do you forget from test 1 and test 2 already if I don't do comprehensive? And if we gotta get you to pass this BOC, if we only did regular tests, I bet half of you wouldn't even pass BOC. You gotta look at your material again and try to build. Okay, so tomorrow we'll take the test first, and then we'll start with circulating anticoagulants.